Welcome to Inspiration Health Radio, sponsored by Millennium Physician Group. I'm Michelle McCormick. You often hear about cholesterol being defined as high or low, or good or bad. Which one is better? You can never remember. Today we're going to talk with Millennium Physician Group's Dr. Albert Lopez Jr. about why primary care providers are the first stop when screening patients for high cholesterol, and why less than half of people with heart disease actually have their lipid panels in check. But first, Millennium Physician Group is a leading comprehensive independent physician group in Florida with more than 560 healthcare providers at 150 locations in 19 counties. We serve almost 500,000 patients. Millennium Physician Group is your connection to a healthier life. Learn more at millenniumphysician.com. Connection, innovation, Inspiration Health. Each week, we talk about healthcare issues that are important to you, inviting providers and experts to inspire you to take control of your healthcare decisions. Join us right now for a healthcare journey as we work together to achieve the best health outcome for you. Well, according to the Center for Disease Control and Prevention, nearly 94 million U.S. adults aged 20 or older have cholesterol levels higher than 200. What does that mean? Since cholesterol, high cholesterol especially, has no symptoms, people don't often know that they even have high cholesterol. So what do the numbers mean? What causes the high numbers? We are so going to deep dive into all of this today with our guest, Millennium Physician Group's Dr. Albert Lopez Jr. Dr. Lopez is an internal medicine doctor at our Roosevelt location right here in Jacksonville. Dr. Lopez, welcome to the show.
Thank you so much for inviting me.
You are welcome. I'm so excited to have this conversation with you today. I know this is a topic near and dear to your heart. So before we even get started into the cholesterol conversation, tell us a little bit about you.
Love that question. I've been practicing medicine about 3 decades. I have a great family, 2 kids, a wife who's also a physician. Been in Jacksonville 27 years. So for a quarter of a century, I was independent and have been happy to join Millennium about 6 months ago, and it's been a great ride. Started with general internal medicine and actually interest in sports medicine and actually performance medicine. Mm-hmm. Slowly moved myself as I took care of young adults in Delaware when I was first there and in Philadelphia. A lot of young adults and doing a lot of preventative stuff, and then moved to Jacksonville, and my median age was a very young 80 years old.
Right.
So there wasn't a lot of exercise going on, a lot of performance sports medicine going on. So my purview started changing to doing kind of cardiovascular risk prevention, a lot of diabetes, a lot of lipids, a lot of hypertension, doing a lot of hospital work. And then I started finding that even though I hit a lot of the guidelines, I still was seeing events that was very frustrating. So at that point, I started looking at what are we missing and what are we doing, and are we really getting to goal, and is goal good? And the goals that we have good enough, or is there better goals to be had? Mm-hmm. And so that's where we were at.
And that's where we are. So let's talk about cholesterol. It's definitely a topic of conversation. I was just at an event this past weekend with a friend of mine who said he needed to lower his cholesterol. So he was working really hard at training for this event, and he lost 20 pounds. But you know what didn't move? His cholesterol. So let's talk about some of the terms that revolve around the cholesterol conversation. LDL, HDL, which one's good, which one's bad? How do you figure it out?
Okay. So you have in the base cholesterol profile, there's 4 factors we look at. It's total cholesterol, there's LDL cholesterol, HDL, triglycerides. LDL is your loser. You want that low. That's probably the most atherogenic or most plaque producing, the most dangerous out of all the cholesterols. HDL, we thought until recently, was your high hero. You want that really high. But now we have some questions whether that's really true. That came out of a heart study probably about 15, 20 years ago called the Milano Heart Study, where they found a gentleman in his 80s and his doc said, oh my gosh, your HDL is only 28 and you're going to have a heart attack. And he looked at the doc and said, what are you talking about? Everybody lives to 100 in my family. None of us have high HDLs. So they went tracing back and found that they had this really kind of what they call a Milano variant, that they had very protective HDL. So HDL may not be totally protective. And we actually found in another study that there's a certain population with very high HDL that they had actually worse cardiovascular disease. So the question becomes with HDL, and we're trying to find the perfect test for that, is there a good functional HDL that does the job of protection? So we haven't gotten there yet. And then triglycerides for a long time was thought of as, you don't need to worry about it too much. For a while, some of the medical societies thought, well, if you're over 400, it's okay. And we never really bought that story because over 400, you'll develop pancreatitis and inflammation of your pancreas. I've always felt that it had to be much lower, and the newer data showing that probably the numbers we're looking at is 150, and that's what you'll see on most of the lab tests. Triglycerides should be under 150. And the feeling was through mainly cardiology was that over 400 probably wasn't so dangerous, but we're now finding that we are developing plaque around 100 to 125, so even the 150 may not be good enough.
Wow.
So now we're driving numbers lower and lower. We do have a lot of studies in the last 20 years that have shown that, and our guidelines have shown lower and lower and lower on LDL, that we thought, well, 130 is probably okay. Well, 160 for a while was like, well, if it's 160, you're okay. But the average person that has a heart attack has an LDL about 136. And if the average person in the United States has an LDL of 134, then why is 2 points a difference of safety versus non-safety? That doesn't make sense. So we started dropping that guideline to about 130. And now if you have risk factors, probably 100. And then if you have a risk equivalent for coronary disease, it's 70, but the Europeans have brought that down to 55.
Wow. So much lower.
So we're really finding in the studies that lower is much better.
Okay.
So getting it as low as you can.
So you hit on something really important, risk factors. You know, and a lot of what you see at the primary care level, a lot of these same risk factors are causes for other ailments. So what are some of the risk factors that we need to be aware of when it comes to cholesterol?
Well, let me take a step back. So the European Atherosclerotic Society made a comment that 75% of premature cardiovascular disease is probably preventable if we modify these risk factors. So, you know, again, what is these risk factors? And, you know, what are the numbers we're talking about? So in the U.S., you know, about 1 million people have died for either coronary disease, stroke, or some other cardiovascular disease. That's a lot of people. And, you know, about every 38 seconds, someone in America has a heart attack. And about every 3.5 minutes, somebody has a stroke. You know, so it's not something that, you know, we kind of poo-poo it, and it's not really high on our chain. If you do studies and you ask people, especially women, which are way understudied and really ignore their risk factors, you know, they'll ask them, what are you afraid of dying from? They'll probably say breast cancer. And people say, you know, most men will say something different, prostate cancer. But cardiovascular disease is probably about 30 to 40% of that, you know, the death in this country.
For men and women?
Men and women. So, you know, the other important thing is, do you want me to talk about, you know, 50% of the people that have heart attacks have a normal cholesterol level. So sometimes not just looking at your cholesterol may not be enough, and we can touch on that later. I know that we wanted to touch that, but you know, you're talking economically. So for us individuals, the economics matter but don't matter. For the government insurance, it matters. You're talking about $350 billion annually in direct and indirect care is the cost of what heart disease costs, right? So that's a ridiculous number.
Yeah, that's really high.
Yeah. So, and I think a lot of it is very preventable because I think there's a better awareness in the last decade. Absolutely. Much more than our parents did. I think the young adults are doing a very good job of kind of mitigating a lot of the risks that we have. But there's a lot of risk factors that people don't even realize and don't even talk about. And I think those are really important.
Yeah, we have, and with an aging community that we have right now, as the baby boomers are aging and as people are getting into 65 and up, they're not stopping working. You know, people are still trying to stay active, very different from our parents even. So it's really interesting to see what's going to happen health-wise, like you said, as the years move forward. But we're going to stop right there. We're going to take a quick break. And then when we come back, we're going to continue this conversation about the cholesterol and the conversation. And we're going to learn more about lipids and risk factors and non-modifiable risk factors. So you're definitely going to want to stick around with Dr. Albert Lopez Jr. from Millennium Physician Group. We're going to be right back. Inspiration Health Radio, sponsored by Millennium Physician Group. We'll be right back. Welcome back to Inspiration Health Radio, sponsored by Millennium Physician Group. I'm Michelle McCormick. Each week, we talk about the healthcare issues that are important to you, inviting providers and experts to inspire you to take control of your healthcare decisions. Well, today we're talking about cholesterol, and you often hear about cholesterol being defined as high or low, good or bad. Today, we're talking with Millennium Physician Group's Dr. Albert Lopez Jr. about cholesterol, about risk factors, and that's where we left off in the last segment. So our guest today, Millennium Physician Group's Dr. Albert Lopez Jr., He's an internal medicine doctor located at our Roosevelt office in Jacksonville. So welcome back, Dr. Lopez. And what you were talking about was so interesting. I mean, the relationship between high cholesterol and heart disease, it's like married. It's like you can't have one without the other.
Yeah, definitely the most significant risk factor we have.
Yeah. So what are the risk factors that a patient who comes into your office, what are you looking out for?
I think you can divide it into modifiable and non-modifiable risk factors. And so non-modifiable is age, can't change your age, sex, your gender, ethnicity plays some factors, socioeconomic status plays some risk factors, and that can change though, right? So that's pseudo-modifiable. Family history you can't change. Mm-hmm. So, and then last thing is actually climate. So we know in the winters there's a higher incidence of cardiovascular disease, and we've kind of had to try to figure out, is that because people are shoveling snow? But we even see that in the South where we don't shovel snow. Mm-hmm. So there seems to be a seasonality of cardiovascular disease.
How interesting. Well. When I saw weather as one of the non-modifiable risk factors, I was like, well, that's interesting. It makes sense,
well,
I
that
suppose.
may also tie into flu season, and we know that inflammation plays a risk factor in cardiovascular disease, and we know that there's an interesting study that was done internationally. It was initially done in China and then done internationally, that during the flu season, there's an increased systemic inflammatory response, and more people had vascular inflammation, and therefore we saw vascular markers go up, and then they had more cardiovascular events, heart attacks, and strokes.
Okay, all right.
So that may be the more intelligent answer,
does,
right?
but it does make sense. Yeah. I mean, because you are more susceptible to being sick, I suppose. But what are some of the risk factors that we can change?
So I think the biggest two that are easy really to change is diet and exercise, or what we eat, and then movement therapy, because so many people are allergic to exercise, right?
Right.
So, eat the rainbow is one of the things I say. You want those 7 to 10 servings of fruits and vegetables in a day. You want to decrease salt intake. We oversalt things in this country horribly, and really it's only 1 to 2 grams of salt a day is the average intake, and we probably do closer to 5 to 6. So we're oversalting our food. We have very low fiber diet. Increasing fiber, good fiber, complex fiber is really big. Decreasing bad fats and increasing good fats, and that's Gary Taubes kind of had a whole book, Good Fats, Bad Fats, but things like avocado, olive oil is very significant in helping in cardiovascular disease, and decreasing things like animal fats, fried foods, etc. And then hydrate. We forget hydration is really important because of long-term kidney damage with that, and systems don't work as well, and vascularity doesn't work as well without hydration. Mm-hmm. Alcohol, the new guidelines or limitation, men 1 to 2 drinks a day maximum, and women 1 drink a day.
Wow.
And it's not that you can't handle it. Mm-hmm. Like, you maybe outdrink me, Michelle, but it's not really good for you.
Right, probably
Actually,
not.
You probably could outdrink
me. No, probably not. But I understand what you're saying. Now, cholesterol being kind of like this hidden threat, right, to us. How do we know when I come in for an annual wellness visit, let's say, you're running my labs, is that where you start to see my cholesterol issues?
Sure. Do you want to continue from here or go to the continued modifiable?
Hey, we can go anywhere you want.
Let me finish the modifiable, because then I'll do a whole kind of thing, because, hypertension's a big, easy modifiable, and especially in certain communities. And so, we really don't get people to goal enough. And there's been a lot of controversy about 5 years ago, where's the goal on blood pressure? And it really doesn't matter what your age is. It's between 110 and 120, and so you really want to get that systolic, that top number, really down. And it's kind of not that hard to think. You've got a pipe that deals with 120 pounds per square inch in it, and you consistently push 140 pounds per square inch in it. It's not going to last 100 years. Mm-hmm. It's going to pop. Mm-hmm. So it's, easy physics, right? So keeping that blood pressure down and deciding what you need is an individualized decision between the physician and the patient, and risk factors. Looking at ravages of sugar. So I'm very big against simple sugars and even carbs. So you have to be careful with the amount of carbs in. Carbs are not the devil, but you still have to be careful how much you place in. And then controlling glucose levels in a diabetic or pre-diabetic is very important. So we forget that even pre-diabetes or elevated fasting glucose doubles the risk of cardiovascular events. But the diabetic has a 4 to 6 times higher elevated risk of cardiovascular disease. So it really changes the game. once you have high sugars. Obesity or being overweight, to get into ideal body weight is really important. Inactivity. So we know that almost every chronic disease, if we become more active, we can reduce those chronic disease long term or improve the outcomes of chronic diseases with exercise. And so that's, that and eating is like your panacea. And then, changing unhealthy lifestyle. Tobacco is another big one.
Oh, yeah.
Tobacco is very atherogenic, and just stopping that. And the last thing is, controlling inflammation and stress. So those are big things. And then we can approach your cholesterol question.
Well, yeah. So let's say, so we're talking with Millennium Physician Group's Dr. Albert Lopez Jr. from the Roosevelt office here in Jacksonville, and about the cholesterol and how to manage cholesterol, or do we even know we have high cholesterol? So yes, I come in for a visit. You say, let's just run a blood panel. I have a red flag. What are you looking for?
So generally, I'm looking for the LDL cholesterol to be at a certain level, and that depends on family history, what your other labs are. So family history of diabetes, family history of prediabetes, family history of early cardiovascular disease, family history of high cholesterol. Those things would change what I'm looking for. So generally, I start with a standard lipid panel. If I've known that patient had high triglycerides in the past, that changes his calculated LDL number, because LDL has been calculated for a long time. So I may go with a directly measured LDL number, and that's becoming much more popular. If I know somebody has risk factors, I may do an advanced lipid panel or inflammatory testing, especially with people that have early cardiovascular disease in their family, or they had a cardiovascular event. One of my peeves is when I look on social media and said, I just had a small heart attack. It's not a big deal. It is a big deal, because the recurrence rate is like 75% for stroke and heart attack. So you can't blow it off like, I just had one event and it's never going to happen again. It's like, it's like a mole hole. If you find one mole hole, there's a million others in your yard, right? You can't just say, it's not a big deal. It's there, and it's systemic. So you've got to kind of mitigate that risk. So I'll start with a standard lipid panel in most people. And then if I find things, then I'll do things. Or if you have other risk factors, I may go into a much deeper depth of looking at things.
Well, you talk about, in your conversations about cholesterol, this triple threat of high cholesterol. Let's kind of break down what the three of those are.
So, triple threat is, and cholesterol is a couple of things. One is the heart attack, the stroke, and then peripheral arterial disease. And we're really just coming back to looking at disease in the legs and lower extremities. And we know that if you have disease in your lower extremities, you double your risk of a heart attack later. So it's not just looking at the heart. You've also got to look at the neck vessels, and then looking at the leg vessels and see. And that's easily done by checking a pulse or taking a listen. If there's more risk, then you may want to do an anatomical test like an ultrasound and see, how does that flow look? Is there inflammation in that arterial wall or not? And there's several tests we can do, like an ABI or a lower extremity ultrasound or carotid ultrasound, or even better, a CIMT, which is a carotid intimal medial thickness test, which not only looks at flow, but also looks at inflammation in the arterial wall.
Does cholesterol affect the flow, like the thickness of the blood in the vein?
It can. So triglycerides, and we talked about this earlier. I have one of my sub things is lipidology. So I do a lot of cholesterol. Patients with high cholesterol or different cholesterols, or patients that are not kind of coming to goal with standard therapy. And so I'll work with them on a number of factors. But we talked about that young lady that had 10,000 triglycerides. And when we drew her blood, it looked like cream on top of, it looked like strawberry milk. It was creamy with a light tinge of pink to it. And so, that's definitively, pro-clotting. So cholesterol can, get into arterial walls, and you need other risk factors for that. It can, an irritated vessel wall can be prothrombotic or pro-clotting. And then you have to look at the inflammation in the arterial wall as well in some cases.
Well, we're going to come back after this break, and we're going to talk about how you take care of that in a patient. And we're also going to move into the Lp(a). We're going to talk a little bit more about that, too. So stick around. Our conversation with Millennium Physician Group's Dr. Albert Lopez Jr. will continue on Inspiration Health Radio right after this. Welcome back to Inspiration Health Radio, sponsored by Millennium Physician Group. I'm Michelle McCormick. Each week, we talk about the healthcare issues that are important to you, inviting providers and experts to inspire you to take control of your healthcare decisions. We are talking about cholesterol and is it high or low, good or bad? We've talked about that in the past few segments about risk factors and non-modifiable risk factors too. Today, our guest is Millennium Physician Group's Dr. Albert Lopez Jr. He's from our Jacksonville office on Roosevelt. And Dr. Lopez, great information, what we've been talking about, but we finished the last segment talking about this very high, thick, milky, strawberry creamy blood in one of your patients. And that's frightening because, I mean, I don't even know how that would even cycle through someone's body at that point, you know? So how did you treat this patient?
She was an interesting case. She's probably the highest triglyceride I've taken care of. And I kind of knew where to go, but I actually called one of my colleagues, one of my mentors. We actually, at that point, there was a strong feeling that EPA, which is a subfraction of fish oil or omega-3 fatty acids. EPA we've known for a long time is cardioprotective. And before we got the data with Vasipa, we started giving her high-dose EPA. And she did quite well. We lowered her triglycerides about half. And then she developed pancreatitis because we were clearing out so much fat. It went through her pancreas and caused an inflammation of the pancreas. So we wound up starting apheresis on her where they take the blood out, filter out all this fat, and then put the blood back in her system. And she had to have that done about, I think it was every 2 weeks or so.
Wow.
And she's done quite well. The interesting story to that is that when you see that, it runs in families. And so we did cascade screening, and she had 2 children, a daughter that was 10 or 11 years old, and a daughter didn't have really high triglycerides, but she had a very, very high LDL cholesterol. And pediatrician really wasn't keen on looking at her lipid profile. We wound up calling them, talking to them. They understood our concern and wound up putting on her statin, the daughter on a statin at 10 years old, and probably saved her life.
Wow. So that leads me to another great question. Back to my friend that I referenced in the very first segment about how his cholesterol was high. He started training for this 10K, lost 20 pounds, didn't drop his cholesterol number. Now is looking at a statin. What is that?
Statin, we have incredible data with. So statin's a drug. Actually, it came from a fungus. You'll also find it in a natural compound. The problem in the natural compound, we haven't found an event reduction rate, so we didn't really reduce, and not really been well studied, this natural compound in reducing heart attacks and strokes. But the statins actually have shown to do several things. It reduces cholesterol, mainly LDL and total cholesterol. It will raise good cholesterol, theoretically good cholesterol, HDL a little bit, and drop triglycerides a smidgen, but not really work on triglycerides very well. But we know that the risk reduction with statins is incredible, and depending on what drug you use, it could be 32% to 54% risk reduction of first heart attack,
That's big.
Pretty amazing.
Yeah.
And it's tried and true. We've seen great studies with it, and the most recent, the newest of the lipid or cholesterol drugs, the last 2, have shown studies with women, which women were not well studied in the past. And there weren't a lot of ethnicity studies, so there's a fair number of African Americans and Hispanics in that study as well. So, we're finally studying real-life populations with it. And it's shown a great reduction. So it reduces LDL cholesterol, like I said, and some of these other factors, but it also reduces arterial inflammation, and it stabilizes plaque quite a bit. So what you get is this inflamed arterial wall from a lot of cholesterol in it, or hypertension, or high sugars, and it kind of stabilizes and solidifies that plaque and makes it more stable and less friable, less prone to rupture.
So does it keep the plaque from increasing?
It does decrease plaque increasing, and it actually solidifies the plaque, and there's some theory that it calcifies plaque.
Okay, all right.
So what we get is, I like the analogy of a volcano and lava. So what you take is hot lava and making pumice stone out of it. And so the pumice stone is not nearly as dangerous as the lava is, and so it cools it down, and it'll always be there, but it's okay because it's not so bad.
Yeah, is there anything in the works to replace a statin?
We have so many drugs that are coming on the market and several that are on the market. So, the EPA or omega-3 fatty acid trials have been hit and miss. Some of them were not really using enough high dose of EPA, so the trials weren't very effective. We have this Vasipa that's shown. There's a new trial just a couple of weeks old now that shows that EPA actually does show benefit, and it didn't show benefit in the prior trials. So we're looking at least Vasipa, and we know the EPA probably has some benefit.
Okay.
We have Zetia or ezetimibe, which blocks absorption of cholesterol from the gut, and that has shown a 24 to 28% risk reduction of a heart attack, and it can lower cholesterol. And I say can, that's if you're a hyperabsorber. So, going back to your friend, here he is, he diets, he loses 20 pounds, he's watching what he's eating, and, I'm going to assume that he did a lot of good fats and cut out a lot of the bad fats.
Yeah, he said he cut
carbs.
meat and alcohol and everything.
Yeah, and so he may be a hyperabsorber, and there's some people who are super high absorbers, but he actually may be a hyperproducer. He'll make cholesterol no matter what he eats. So genetically, he just tends to make more and doesn't kind of take it out of circulation, and may not have the enzyme or the whereabouts to take it out of circulation and kind of get rid of it.
How interesting.
So you have to look at it in the different mechanisms of cholesterol. And so I love doing this to physicians. I show them, it's not as easy as just a statin, just total, even though it does reduce risk, it may not be the only thing you can use. There's other pathways. And when I show the pathways of lipid metabolism, it kind of looks like an energy field. It's kind of like, lines everywhere, and people kind of seize on me and go, oh my gosh.
Well, there's not a one-stop fix-all, is there, Dr. Lopez? No. I mean, you just can't say, you know what, this is going to be used to treat everybody.
Right. And it doesn't work.
And it doesn't.
And there's a certain small percentage of patients that have muscle aches or issues with it. So we have a new drug out called Benedoic Acid. I'll skip the trade name. And Benedoic Acid does not go through muscle, so it doesn't cause muscle aches. It can raise uric acid level a little bit, and it can sometimes cause joint pains, but it effectively takes cholesterol out of the system as well. So this is a drug that is kind of been touted as for people that can't tolerate statins or an add-on to statins. And then a couple of years ago, we came out with these injectables every other week, PCSK9s. We have 2 of them out. And these have shown incredible reduction of inflammation, of LDL cholesterol, and shows positive outcomes where reduction of heart attack and stroke with it, and peripheral arterial, I think there's peripheral arterial disease data with it as well. And then we have new drugs coming in the pipeline. And so I've been working with a research group, and I'm working with 4 other drugs. And it's just amazing. We're going to very soon have a very large armamentarium under our belt to help change cholesterol profiles. And then I think one of the most exciting things is we have a drug that's just been approved in the United Kingdom, which Dr. Corin worked on, and I kind of was a sub-investigator with, called Clyceron. And it's an injection every 6 months. So it's almost like a vaccine.
Wow.
And it's really indicated for these very high familial hyperlipidemia patients that have very, very, very high cholesterol. That's really the indication right now, but who knows where it'll go if it shows good outcome.
Right. And that's what the trials are good for, too. So you got to have the trials to know where you're going to go with it.
Absolutely. But we, so often we can't get people to go. You have people changing their lifestyles, they're changing, exercising, and they still have high cholesterol, and it's just innately there. And so, they need a little bit of help, and it's nothing wrong to getting some help with that.
Mm-hmm. So, I think that's kind of where he's this friend of mine is falling into, is he's like, I thought I was doing the right thing,
He is doing the right thing.
And I'm going to tell him that.
Yeah, he is doing the right thing.
I'm going to tell him that.
Exercise can reduce, just even walking can reduce 15 minutes a day, every day, can reduce cardiovascular events almost like 10 to 15%. And then, people that exercise regularly and even with resistance training, with aerobic training, have shown up to a 35 to 40% risk reduction. So that's a pretty amazing.
Does age matter at that point?
Age really doesn't matter. We see that if people have been athletes and come back, or been exercising and come back to it, they do very well and adapt pretty quickly. You just have to start slow and work your way up. But even, the earlier you do it, the better the outcome, especially before 40. But there's data on 60-year-olds just starting exercising and doing very well and actually reducing risk. Mm-hmm. And we see this with cardiac rehab. People that have never really exercised, they get their monitors put on to see what their rhythm's doing because they hurt from having open heart surgery, and they start walking. And we see them actually do much better.
I love that.
And, they can walk farther, they feel better, they can breathe when they walk, so they have a lot less risk going on.
Well, I think that's super important. I mean, it's like, it doesn't matter when you start, just do something.
Just do it.
Just do something.
We're not built to be sitting down.
Right. I agree with you, Dr. Lopez. All right. Our guest is Dr. Lopez from Millennium Physician Group, internal medicine doctor in the Jacksonville area in our Roosevelt office. And coming up when we return after the break, we're going to talk about that Lp(a). What is it? and how can we learn more about it? So you're going to want to stick around. The conversation will continue on Inspiration Health Radio, sponsored by Millennium Physician Group, right after this. Welcome back to Inspiration Health Radio, sponsored by Millennium Physician Group. I'm Michelle McCormick. Each week, we talk about the healthcare issues that are important to you, inviting providers and experts to inspire you to take control of your healthcare decisions. You often hear about cholesterol being defined as high or low, good or bad. Well, we have really hit cholesterol from so many angles today. Our guest is Millennium Physician Group's Dr. Albert Lopez Jr., primary care provider and internal medicine doctor right here in the Jacksonville area from our Roosevelt office. And Dr. Lopez, you're very, very passionate about cholesterol and treatment of and prevention of. We definitely need to talk about this Lp(a). Tell me, what is it? What is it all about?
So this is my new kind of bugaboo that I've really been into. So I've been watching Lp(a) for about 20 years. And so Lp(a) is a protein, and we think, so nerd moment, we think there was a function for Lp(a). We think that it probably, let me go back to what it does. Mm-hmm. It affects about 1 in 5 people globally. So you're talking about 1.4 billion people worldwide that it affects. So imagine if we can have a drug that affects 20-30% of the global population, and we can reduce that risk for cardiovascular disease. And so Lp(a) is this kind of protein that is a very big risk factor for cardiovascular disease. So it's a modifiable risk factor, and it's independent related. So the higher the Lp(a), we think the higher risk of heart attack and stroke someone will have. And it's this kind of nasty little protein that kind of attaches to LDL cholesterol, and it makes it much more atherogenic. And it also is kind of a quadruple threat or triple threat. It's prothrombotic, which means it makes you clot easier. So that's a problem if you're having a heart attack, because you're already closing off that vessel wall, and if you promote more clotting, it's going to close off. And because of that, it may actually not fully clot, but cause more turbulent flow, which will make things worse. It's atherogenic, or makes more plaque. So it can take even a normal LDL cholesterol and make it very plaque producing. It's pro-inflammatory in nature, so it sets up an arterial wall inflammation and valvular wall inflammation, and it increases the risk of aortic valve stenosis, specifically the aortic valve, which is kind of interesting. And so what was the function in the old days? We think because it was a pro-clotting agent, we think maybe way back when we didn't have a lot of medicines, it may have been an aid in childbirth, so women didn't bleed to death during childbirth, so baby can survive. If there's no mom to feed baby dies. Mm-hmm. Or if you're a hunter-gatherer and you gorge yourself, you may be able to clot and heal faster. So we think that may be the kind of the nerd answer to it, but we're not sure. There's always a reason why something comes about, right? But now that we're living much longer, because, right, the median age back then was in pre-Neanderthals, right, or Neanderthals was 30 years old if you were lucky. Now we're talking 80, 90, 100 years old. Right. So it doesn't do us any good, especially me now moving into never mind what decade.
We don't talk about age on this show, Dr. Lopez.
You want to live a little longer because you just figured it out. Right. So, this is a hidden risk that nobody really knows the numbers. And the problem is that most people have no idea if they have Lp(a). So we actually have 2 drugs that Dr. Carr and I are working as principal investigator on, from 2 different companies that we know lowers it markedly, almost 80%, and we're looking to see if the outcomes are there in reducing cardiovascular risk with them, which is very exciting, because imagine changing 20-30% of the global population in cardiovascular disease. That's incredible.
Well, and Dr. Corin, you work with him at Encore at the Jacksonville Center for Clinical Research also. So that's exciting that there's that happening right here in our backyard too.
It's a hidden treasure. Dr. Corin's been trying to get to me join him for 20 years, and I finally conceded about 5 years ago, or a little less. And I asked myself, why did you wait so long? This is so much fun.
Yeah. So you guys are working on some like groundbreaking science here.
Yeah, it's not just in cholesterol. We've done diabetes. We have a psoriasis trial. We're working on respiratory syncytial virus. We worked on all the vaccines. We worked on the monoclonal antibodies that treat COVID. We have an Alzheimer's research also that we're doing, which is there's not great drugs out there
Right,
now.
right.
So we're doing a lot of really groundbreaking research, which is really cool.
Well, and this one about the Lp(a) just sounds fascinating because if you don't know it's there, how do you find it?
Right. And that's a big thing that I tell people all the time is know your numbers. What's your LDL cholesterol? You know, what is your heart rate? What's your blood pressure, right? What's your goal weight? What's your weight? What is your fasting sugar? You know, what is your Lp(a), especially if you have risk factors? So, knowing your numbers is a really big deal because now you can try to get yourself to a goal. We know that it's much safer and have better longevity, right? You have a better quality of life later on. So it's not just about how long you live, it's the quality of how you live.
Right, right.
And so that's what we're trying to do with all this.
So we're talking with Millennium Physician Group's Dr. Albert Lopez Jr. from our office on Roosevelt. You know, with cholesterol and with Lp(a), you know, who should get tested?
Right. So, the big factor to look at is, especially with cholesterol, is if you know your number, and we should really start testing probably in our 20s. If you have a family history of very high cholesterol, probably earlier than that, and we're pushing teens or even young adults if they have familial hyperlipidemia, probably at a younger age. There's two camps on who do you test for Lp(a). Some people think that everybody should be tested once in their lifetime at least. And then some people say, no, just the people that have risk. I'm in the camp that I think everybody should be tested once.
Is it covered by people's insurance?
It is covered right now. There's what we're trying to do. If you really want to research more about it, the FH Foundation has an Lp(a) subsection and a familial hypercholesterolemia subsection. And there's a lot of good data on it, but we're trying to build data with FH Foundation to bring to payers, to bring to the general populace, and to bring to physicians that these are really big risk factors that are modifiable, and we can really change people's lives.
Yes.
And so we've seen people with very, very high Lp(a)s have heart attacks in their 30s, and changing your whole life. Or people with familial hyperlipidemia and Lp(a), which can happen, has a markedly cumulative exponential risk. So if you have high cholesterol, you have a risk for cardiovascular disease. If you have inflammation, you have a risk for cardiovascular disease. But if you have Lp(a), you have even much more risk of developing cardiovascular disease.
What about the patient that doesn't have any family history, has never had any heart issues, doesn't have cholesterol, high or low, but maybe they do have a little heart attack?
Yeah, and there's no really such thing as a little heart. You may have a little bit of damage in your heart, but the disease is there, right? So it's mitigating that risk or decreasing that risk. And so, to go back to who you treat, and I think some of these hidden things we don't know, people don't realize that if you had a heart attack or any kind of vascular disease, leg disease, carotid disease, right, vessels in the neck, or had a stroke in men younger than 55 and women younger than 65, that's a significant risk. Aortic valvular disease. So if the valve in the aortic valve, they have disease at a young age, and I have a great case to talk about in a minute, that's a risk factor for Lp(a). Statin-resistant patients, what I mean is they put them on a statin and their LDL doesn't go down very much. And the old standard part cholesterol profile, Lp(a) is mixed into that LDL. So you're dropping LDL, but you're not dropping Lp(a), so the number doesn't go very low.
Right.
So they're kind of statin, quote-unquote, resistant, but they're not really resistant to statins. People with strong family history, but you already said, what if they don't have those? People with cardiovascular disease with normal cholesterol may have a high Lp(a). So family members with high Lp(a) should be checked as well. And then diabetics. We know there's a higher propensity of diabetics to have elevated Lp(a). And then people with familial hypercholesterolemia definitive should have Lp(a) checked.
Okay.
And then I think everybody should be checked. Like I said,
Yeah.
20 years and above, you don't need it every year, but, checking every 5 to 10 years just to see where you're at. And obviously, if you have a big life, you gain 30 pounds in a year, you need your cholesterol checked again. You need to be checked for diabetes.
Right.
So checking those numbers is really important.
I think that's excellent advice for listeners. Was there a case you wanted to touch on real quick?
Yes, we had an interesting case before we had any drugs for Lp(a), and this was a very lean, about 50-year-old nurse manager at the hospital I worked in when I was doing still hospital work. And in fact, never used the elevator, always went up flights of stairs, up and down flights of stairs, exercised regularly, very good shape, and family history of early cardiovascular disease and was being checked regularly by a prominent cardiologist in town. And He came to my office and says, I know something's wrong with me. I'm going up steps and I'm really winded and my chest just feels not really pain and not really tight. It's just different. I just feel like a heaviness in my chest. Did an EKG, it wasn't any different. It was a little bit different, but it wasn't really very different. I called up the cardiologist and I said, I have a funny feeling about, this gentleman, and I really think she should be looked over. And he says, we just looked at him less than a year ago. We did a stress test, we did an echo, and he looks fine. I said, something's different. And this guy's not a complainer. We need to kind of recheck him. So he brings him in, and he does a stress test on him, and he totally fails his stress test. He doesn't do well with it. So they do a cath, and they find he has some kind of ratty disease. And then he does an echo and finds his aortic valve had really tightened up within like the 9 months, like all of a sudden accelerated and tightened up.
Wow.
And wound up looking back in his chart after he had called me and said he's going to have valvular surgery and we're probably going to put 2 stents in him. Looked back in his chart and he had a very high Lp(a), over 200.
Goodness.
But we had nothing to do. And so what did we have back then? We had niacin. Well, nobody uses niacin anymore except for probably me. It drops at about 8 to 14%, but people flush. So people with very light eyes, light skin, flush horribly. And women kind of giggle at their husbands because it's the revenge for menopause. You can do the apheresis like we talked about, but, not really well accepted, and there's not a lot of places to do apheresis. You can use cholesterol transfer protein inhibitors, another drug, mipamycin, another drug that you have to have a doc that knows how to give this drug because there's risk with it. The PCSK9s reduce Lp(a), but it doesn't have an indication for it, even though it reduces it like 23 to 30%. And then there's the clinical trials in these drugs that actually helps as well. So know your numbers.
Yeah, know your numbers. Bottom line, and go see your primary care doctor. Yeah. Get it done. Well, Dr. Lopez, thank you so much. Dr. Lopez can be reached at our 4291 Roosevelt Boulevard office. The phone number there is 904-598-1888. And we're thankful that you came on today to talk to us about all things cholesterol and learn a little more about Lp(a), which I think we'll be hearing a lot more about, especially if it becomes more of a routine check with primary care doctors. So, Dr. Lopez, thank you so much.
My pleasure.
The conversation will continue next time on Inspiration Health Radio. Your healthcare journey is important to us, and our goal at Millennium Physician Group is to work together to achieve the best health outcome for you, and that starts with seeing your primary care provider. Go to our website for a full list of offices across the entire state of Florida. Our provider is also listed there at millenniumphysician.com. In good health, I'm Michelle McCormick. Have a great day.